Dementia in the United States is expected to double by 2026, reaching 1 million new cases a year. And in the next 5 years, the number of people aged 65 and older with Alzheimer's is expected to reach 8.5 million, primarily due to the aging population. And neurological conditions are the leading cause of ill health and disability worldwide. Now, Macy, I was doing the research on this, and when I saw that stat, I Googled a couple of times because that just with all that we hear about heart disease and cancer, that just didn't seem right to me. But in fact, it is. And over 3.4 billion people are impacted by neurological conditions.
And yet some people grow old so gracefully that you would never guess their age. They're your go-to for the crossword puzzle. They have the stamina to go for a run on most days. They're always up to keep the grandkids all weekend long. When I see people like that, they truly inspire me. I want to be just like them when I get older, in mind and also in spirit.
But the question is how? What can we do to preserve our mental acuity in general, and especially when genetic factors are at play? How do we live our best lives when we get old? Are we to believe all the promises of supplement companies? The answer comes in a powder or pill form. But do they really work? What is the science behind aging gracefully? Hi, I'm Matt Eves.
And I'm Macy Jepson, and this is The Science of Health. We already know that diet and exercise factor into our longevity, as does our family history. And Matt, we've talked on this podcast and a lot personally about my mom's battle with Alzheimer's disease. We lost her at a relatively young age in 2017. So I really should be encouraged by all of the brain boosting supplements, all the diets out there. But to be really honest, I'm not confident that I can use any of that and truly prevent what could be my fate.
Yeah, Macy, hearing about your mom, unfortunately, I think much like cancer, we all know someone in our lives that is dealing with or has dealt with dementia or Alzheimer's. My grandmother had a rough go of it. It was probably 20 years ago, and I can still vividly remember my interactions with her, especially the interactions my mom was having with her near the end. Today, we're tackling the promises out there by separating myth from fact. Joining us is Dr. Mohammed Al-Qasabe. He's a neurologist who specializes in memory and movement disorders at University Hospitals in Cleveland.
Thank you so much for having me.
Let's start with the big thing. When I was researching this, is there a difference between Alzheimer's and dementia? Are those different diseases? They're the same?
People wonder about the difference between Alzheimer's disease and dementia. And if we start just defining each one, I think dementia is more a category. So itself is not a diagnosis, but it's a constellation of symptoms. And I would say it's used as an umbrella term. The main thing that characterizes this is interference with day-to-day function. So this is considered dementia. So itself is a category, can be caused by different etiologies, including Alzheimer's disease, including vascular dementia, including frontotemporal dementia, dementia with Lewy bodies. And what is commonly seen in clinical practice is what we call multifactorial dementia or mixed dementia. If we talk about Alzheimer's disease is considered the most common type of dementia. It accounts for at least 60 to 80% of cases. Alzheimer is a neurodegenerative disorder. On the pathological level, there are certain proteins that accumulate in the brain. When they accumulate in the brain, they can interfere with the memory and learning. They can also interfere with other cognitive abilities, including judgment, problem solving. Later on can affect the language, and it can also cause behavioral changes as well.
All right. You've just unpacked a lot under that umbrella, if you will, of dementia. Are the risk factors for everything that lives under that umbrella the same?
So I think it's a very good question, Macy. We need to probably differentiate between two main categories in risk factors. We have what we call non-modifiable risk factors, like our age, our family history, our genes. But there are other modifiable risk factors that can vary from like history of head injury, history of hypertension, diabetes, excessive alcohol use, smoking history. All these factors could be modifiable, including like lack of exercise, sedentary lifestyle, bad dietary habits. So it depends what we are talking about. So we can probably take some measures to improve the modifiable risk factors.
We're definitely going to dig into that later because we want to know if there's anything we can control. And how do we make that happen? But first, I want to talk more about the damage to the brain. What's happening in the brain that causes these diseases?
So if we look at the Alzheimer's disease, we have, the most accepted framework is what we call the ATN. And ATN stands for A is amyloid deposition. and T is the tau deposition. And then we have the N, which stands for the neurodegeneration. So this is basically the cascade of events that happen during the pathology, like when the pathology of Alzheimer's disease develops. What we also know from the research that the pathological changes for Alzheimer's disease start to happen up to 20 years before patients start to have symptoms. So it's a very slowly progressive disease that starts at different stages until it comes to the point when the patients start to notice symptoms.
When you're talking about the constellation of symptoms, at what point, I'm getting to the age where I felt like when I was younger, I had a sharp memory. I wouldn't take notes in meetings. I could remember stuff from 3 days ago, like a blink of an eye. And now I struggle sometimes to put those things together. And it's like, man, what was the name of that? I have to think back. At what point does that just sort of where you can differentiate between old age and there are probably some neurological issues starting to come on, and should people be reacting to those? Like, is just being a little forgetful, should that be worrisome? Or it's like, no, it has to get to the point of X, Y, and Z before you should start thinking about intervention?
Yeah, I think this is a fantastic question, Matt. And the reason I'm smiling because this is what I get when I see the patients. Like I have the caregiver who is concerned about the patient's memory, but the patients say, I'm getting old. What happens, we look at the cognition as a continuum as we get older. There are certain areas of our cognition that can change even when we are in our 30s, like our processing speed is not as quick as we did when we were kids. And then if we look at the other stages of this continuum, we look at what we call age-related changes. We can see some, changes in our cognition, but the main thing that they are not considered extreme or considered abnormal for age and education. You need to look at the full picture. You need to see like who you are talking to. What is the educational level? Are they retired or working? Are they having different comorbidities? What are the medications? So we need to evaluate patients in their own context. So this is very important. So age-related changes can happen, but what is important that it does not really interfere with their day-to-day function, and these changes are not considered abnormal for their age and education. Then you come to the next stage, which we call mild cognitive impairment. So mild cognitive impairment, there are some cognitive changes that can be seen in day-to-day function, but patients are still able to independently manage their day-to-day function. Then if things progress from here, we come to the next stage, which is mild dementia. So mild dementia is technically defined when we have interference with our day-to-day function. And typically, I'm saying mild because usually this is how things progress. Like from mild cognitive impairment, you go to the next stage, which is mild dementia. So people, when they start to struggle with certain areas in their day-to-day function, they start to struggle with the more complex tasks, like managing finances, driving a car, things like that. So multitasking. But they are still able to manage their basic daily living activities. And of course, what matters the most is what we call the longitudinal follow-up. So we need to see patients over time to determine how the symptoms progress over time or they are stable. And it depends what's the underlying cause, because sometimes patients have mild cognitive impairment and we follow them over time. And if it's related to underlying Alzheimer's disease pathology, it's about 10 to 15% of annual rate that they convert to mild dementia. But if it's unrelated to like dementia, if it's related to other things, that's very important to clarify as well when we take the history. So let's say some patients who have uncontrolled depression, some patients have untreated sleep apnea. So all these comorbidities can lead to mild cognitive impairment, but in nature, this is not something that progresses over time if we treat the underlying cause.
And so for you, is it, when you have a patient in front of you, it sounds like the line is there has to be some sort of disruption in daily life or something that used to be easy to do, or you would consider most people being able to complete a task like driving a car easily, that becomes disruptive. Like, for example, I was just sort of thinking in my head as you were saying that, like, I don't know why this has happened lately, but every time we leave for a long weekend or a vacation, we get to the top of the neighborhood, I've convinced myself that I haven't closed the garage, and then we have to turn around and go back and look to see, yep, it's in fact closed and never been open. We've never left it open. So, I think about like, are those kinds of things like concerning, or is it no, like it has to get far worse than Like things like you're not able to remember something you did 20 seconds ago, or you're overthinking situations?
No, not necessarily. So, this is like, what we call, it's a function of attention. So if we didn't pay attention to what we did, this is something that can happen to everyone. Like you are in the supermarket.
That's what I tell myself on a regular basis.
Yeah, you are shopping, for example, and you went to a certain aisle and you start to ask like, why did I come here? And then you start to check your shopping list. This is something that can happen, It doesn't necessarily mean that, you have any kind of significant cognitive decline. What matters the most is when we are evaluating patients, we need really to get history from the patient and what we call a knowledgeable caregiver. So someone who knows the patient well to tell you what is what we call the pre-morbid level, like how did this patient perform in the last 3, 4, 5 years before all these started? And then you compare it to the current level of functioning. And then based on the difference, you can really determine where the patient at with their cognitive status.
This leads me to a memory that I think is worth sharing. We talk about disruptions. For my mom, she was caring for my grandmother who was ill. And she was on a mission, they gave her purpose and she was hyper-focused on that. After my grandmother passed away, we saw an immediate decline in my mom's mental health. The death isn't what made her memory bad, but letting go, I think, is where she finally began to show the real signs of Alzheimer's, if that makes sense.
Yeah. I think it makes perfect sense. And we also get this a lot, Macy, in the practice, like patients trying to correlate the beginning of cognitive decline with certain events, like having COVID or being hospitalized for UTI. And since at that time, patients never came back to their baseline. So I try to dig more into the history because I think what happens, that there is probably, as we mentioned, some subtle changes that patients don't pay attention to, and probably caregivers as well. And then there is a major event that unmasks the underlying cognitive decline. And then we start to see things more clear. And the other thing that can happen as well, in this particular situation of losing like beloved one or something, this could be like what we call a grief reaction. This can also present in terms of like lack of concentration, lack of attention, lack of interest, some apathy, and then we should reassess because patients can remain in this stage up to 1 year. So we need to see them actually frequently and try to determine if it's really something related to that particular event and they probably improve over time, or this was just an unmasking event of something going on very slowly and then started to become more noticeable.
Interesting.
To build on Macy's question or story a little bit, as I think about my family and friend circle, especially those who are older, it feels to me like the ones who are the most mentally sharp or the healthiest there's kind of two things in common. One, they exercise, or maybe exercise is probably a stretch. They're active, ride a bike, they go for walks, they're outside, they're doing things. And then also they have a social circle. So they have things to do during the day, whether it's yoga or there's bowling, or they have friends that they go watch a baseball game with. When you're dealing with your patients, are there things that people can do? Like if are those things you recommend? Is my sort of uneducated or observation accurate in that being active and having a social circle are good things to maintain mental health, or is it not? It's just kind of coincidental or correlational?
I think this is a wonderful question, Matt, because this is definitely relevant. And this is part of my visit with every patient and caregiver to educate them on the management plan. So after we reach a diagnosis, we talk about management. So I always tell them there are two main directions we need to go parallel to each other. One is what we call the non-pharmacologic approach, which contains different aspects, including lifestyle changes. And these are mainly three main things, staying active on a physical level. So exercise regularly is always helpful. And staying active on a mental level, like doing things like brain games, reading, crossword puzzles, and also staying active on a social level. So they stay around people, because some of patients, when they start to develop some cognitive decline, they become more withdrawn. They don't feel comfortable staying around people for a long time. So definitely this would worsen symptoms. So we need to always tell them, stay active on these levels. And on the other aspect comes, what we call the pharmacological approach. So it depends what type of dementia and what type of symptoms, we determine the management plan based on that.
I seem to notice, especially, with commercials out there, that just drink this, eat this, don't drink alcohol. That's a big one right now. I mean, is it really that simple too, or that important? You just mentioned some other things that help, but what about that diet?
There is a lot of research in this area, regarding alcohol. Excessive alcohol is harmful. Moderation is good. So they asked me what type of diet they can follow. There's a recommendation for what we call the MIND diet. So the MIND diet, this is actually a kind of hybrid type of diet. That's part of it is a Mediterranean diet, and part of it is DASH diet, which is the diet that's used to help reducing the risk of hypertension. So we try to do a mix of those. And in simple words, what kind of food they can use, I would say just food that's rich in vegetables, rich in fruit, and also whole grains, less saturated fat, less fried food, less sugars, less pastries. Good things include certain diet that's rich in omega-3, like salmon, olive oil, nuts, things like that. So those are things that can be helpful, or they are considered healthier type of diet. So diet definitely would be helpful part of the management. But I want to also say that we don't have definitive evidence that a certain type of diet could prevent Alzheimer. We don't have this evidence. And also the effect of diet could be modest and could be very individual based.
Yeah, doctor, it's good to hear you say that, because working in healthcare, part of my role is to stay on top of, what's coming out in terms of the latest trends. And then we also, use social media and experts like yourself to say, what do you think about this? And one of the things that's confusing for us is it feels like, especially around the topic of dementia, is anything that is slightly healthy keeps it away, and anything that is slightly unhealthy that's going to be your onset later in life. And so, for the average person, to your point about moderation, there are things that probably we do that are slightly unhealthy, but it's enjoyable, or we like, to have a piece of cake or sugary snack every once in a while. But I think putting this fear in people's heads that if you're not on this perfect track all the time, man, you're right off the rails down this road of, well, you're on the road to dementia. And I think it creates this fear. And so, hearing you say, it's look, yeah, you should eat a healthy diet, but this idea that if there's one path, and that's the path that you got to stay on.
You need to be, reasonable in your recommendation in order to be followed. And the other thing I would say, they need to enjoy their life too. So I would say that's important to maintain that balance. I think the main message is everything in moderation is good, and having a balanced diet is very important. And, other thing I notice also, especially in older people, that they don't pay attention to hydration. So hydration is very important. So they keep working in the yard, and, it's very hot outside, and they feel dizzy, and some of them, experience falls. So I always encourage them to hydrate themselves and make sure that they drink, enough water during the day.
Can we get what we need with a good diet, or can we get more of what we need with a supplement? Is there any science behind that?
So I don't think, that there are, some concerns about using supplements. So first of all, we don't have well-controlled studies that actually involve the supplements and compare them to placebo, as we have for regular FDA-approved medications. So the environment of testing those supplements is not controlled. So don't really know how much this would be a real effect versus placebo effect. And the other thing is their interactions with the other medications the patient's on. So we know that most of the patients have other comorbidities, and they are on different medications. So we want to make sure that those supplements don't interfere with the other medications they are using.
What are you seeing in your office as far as common interactions with medications?
So, patients, for example, who are on anticoagulation, or patients who are taking certain anti-seizure medications, these level of these drugs in the bloodstream can get affected with certain supplements. So this is very important, to review the medications, including supplements, and make sure that we will document that and talk to the patients about, for sure.
Don't do it on your own, for sure.
Yes. Has to be a separate question during the history. And of course, we have the medication list, that we go over with the patients, what's active, what's inactive, and also ask them if they have any other medications that are not listed or supplements.
You mentioned hydration earlier and the importance of that. I never really thought about that. I think that's an interesting one. The one I do hear often, and I don't know, you can tell me if this is true or not, but the correlation between sleep and dementia. So people who have poor sleep habits earlier in life or in their 40s and 50s are far more likely to get dementia because they're not sleeping well. And maybe to answer the question, kind of two things. One, what happens at night to our brain when we go to sleep? What is going on there? And then two, is lack of sleep correlated or causational to dementia?
So I cannot say that it's a cause, but definitely it's a risk factor. Remember, the sleep is actually, that's the time when we basically recharge and our brain recharge. And this is a time that the brain gets rid of any harmful metabolic products or things like that. So this is very important that patients have good sleep hygiene. And this is one of the things that I always screen for when I evaluate patients. What time do you go to bed? What time do you wake up? Do you take any naps? Do you feel refreshed in the morning? And of course, there are certain questions related to our history, like when we talk about dementia, maybe it's a caregiver question, or a bed partner. I ask them, does patient snore? This could be also a risk factor, for developing cognitive decline, obstructive sleep apnea. If it's untreated, this is something that we definitely screen for.
I don't have anything that dramatic, but the older I get, I just want a good night's sleep. So I will occasionally take one of those, I won't say brand, but something with a PM added to it. And you burst my bubble while we were preparing for this because you said that could be an issue. Tell us about that.
Yeah, that's correct. One of the things I see very commonly in patients, medication lists that they are using as a kind of like relaxing tool or maybe something that helps them falling asleep. And the problem that all these preparations, or most of them, they have what we call the antihistaminics. So antihistaminics can cause actually potential side effects of brain fog, confusion. They can affect patients' attention. There are certain medications like zolpidem and similar medications. They are considered central nervous system depressant agents. And this kind of agents have potential side effects. Patients in older age become more sensitive to that. So they can cause inattention, they can cause confusion, they can cause brain fog. They can affect cognitive abilities if they are used for long term.
If I'm understanding you correctly, it's the side effects that you're more concerned about, not necessarily those drugs doing damage to the brain.
Yes.
Okay. That makes me feel a little better.
There's been a lot in the news recently about genetic tests, and even people have taken them and they have the marker for dementia or Alzheimer's. And I don't know. I think about often for myself, like, would I want to know? I don't know, Macy, for you, would you take the test?
I have not taken it. And I think that I would if I were convinced that having that knowledge would change my outcome or change my quality of life. I'm not convinced yet that that's the case. So what I don't want is to learn that I have this and that it's just going to, go down that road and there's nothing I can do about it. Who wants to live that way? And if it came back negative, that certainly wouldn't mean that I would be spared. So I have given it a lot of thought, Matt. And at this time, I have not done it. Doctor, I am open to a conversation if you would like to change my mind. I love being informed. So.
Yeah, actually, I agree with you. So I think the basic thing starts with understanding what does it mean and is it really important that we do that? So first of all, we have to differentiate between two types of genes. We have what we call risk genes that mean when we have them, our risk to develop Alzheimer's increased, but it's not guaranteed. And not having them does not mean that we will not get Alzheimer's. So this is part of it. The other type of genes is what we call the deterministic genes. Deterministic genes, they are rare to begin with, and they tend to happen more in familial Alzheimer's disease. The likelihood of developing Alzheimer's disease with these genes is pretty high. So this is something that happens rarely, and this is something that's seen more in early onset Alzheimer's disease, means that people who develop symptoms before the age of 65 and who are having multiple family members affected by Alzheimer's disease.
Let's talk about the worst case scenario. That one where you said, yeah, pretty good chance that you could end up with Alzheimer's if you have this. What can we do for those patients? What can they do with that information that can change the quality of their life?
So I think, we have different aspects. First of all, of course, patients are concerned when they have multiple family members and they develop this at an earlier age. So it's very understandable that they need to know, like, do I have this or not? So if they turn out to have this kind of genes, like, what should we do? If they are younger, and probably most of them don't have any symptoms. So I would say they start with following, healthy lifestyle, trying to follow like a regular exercise routine, having healthy diet, try to avoid any of the modifiable risk factors, like stop smoking, no excessive alcohol, avoid any kind of risk for brain injury or head trauma, things like that. And this is very important to follow. The other thing I would say, since they know that they are at increased risk, that probably can encourage them to participate in research if they are interested. This is something that can help, other people and help the field to develop new treatments, or maybe having, more understanding of these underlying etiology.
They're talking about medications that could prolong the onset of the disease or the progression of the disease. Is that what you mean by research? Or maybe that doesn't even happen until you have a diagnosis?
So actually, there are different, clinical trials, and some of them are actually looking at what you are talking about. So there are certain, what we call the disease-modifying therapies. And we have now 2 medications are approved by the FDA to be used in early Alzheimer's disease. And when I say early Alzheimer's disease, it has like people who have mild cognitive impairment or having mild stage of dementia. But it has to be due to Alzheimer's disease to be qualified to receive these medications. This is on the treatment level. Actually, there are trials going on to see if starting these medications for people who have pathological changes in the brain, but they don't have symptoms, can help maybe delaying the onset of the disease or not. I don't think that we have to date any positive study in that regard. I think there were some studies, they were negative, but I think there is a lot of studies going on for this kind of early treatment. And also what we know about the medication that are approved, there are other medications in the pipeline to help, slowing down the disease progression so patients can enjoy their independence for a longer time.
And my guess would be for those that are non-pharmaceutical type studies, you're trying to isolate environmental variables, or at the very least document them, so you have some sort of baseline to say, because right, if I have the gene but I'm engaging in unhealthy behavior, or if I don't have the gene and same thing, engaging in healthy behavior, it's going to have an impact on what the percentage likelihood is, right? And so just the gene itself, it's sort of the nature-nurture conversation comes into play, right?
That's basically what we're trying to explain to the patients. We have 2 main categories of risk factors. One we cannot really change, and one we can. So let's start with what we can and then see how things go.
When your grandmother passed away, there was no test that could have said it was Alzheimer's until after she passed. Right. And it wasn't much better when my mom passed away not many years ago. But Doctor, from what you just described, there are ways to find out if we are in fact dealing with Alzheimer's at an earlier stage now.
Yes, that's true.
That's very hopeful.
Yes, definitely. And, I think this, like a lot of, biomarkers are like being studied now. And I think we are in the era of biomarkers. I think there is a lot of excitement around this. And the reason for that is not only to early detect Alzheimer's disease, but the other, way to be really happy about this and celebrate this, that we have now treatments for early stages of Alzheimer's disease. So basically what you can do, you detect early and you treat early. So you can help patients, enjoying, their life for longer or have their independence, by slowing down the disease progression. So I think this is very important. And there are different biomarkers, it depends, what we are looking at. There are different imaging that we can use. There are different biomarkers in cerebrospinal fluid, like using a spinal tap, or more like, emerging now are the blood-based biomarkers. So there are some blood tests that can test for Alzheimer's disease.
You mentioned earlier about brain games or things that we could do to stay sharp. Do those really work? Is the brain like a muscle, and if you exercise it, it keeps it healthy? So is doing Sudoku or other puzzles or things like that, or just anything that's mentally challenging, is that helpful?
Yes, for sure. I think there are some studies actually looking at the opposite, like people who don't, use any kind of mental activity and people who are isolated and they are followed for a longer time and they actually found to have a higher risk compared to the people who are like mentally active and socially engaged. So I think this definitely matters. And, it's like, the way that we just say it in simple words, like, if you don't use it, you lose it. So this is something that you need to train all the time, at least to keep your cognitive abilities, active and intact.
It's great to hear. So a lot of times with Alzheimer's or dementia, we're thinking about the patient, but having lived it as well as knowing other people who have done it, we hear a lot about the burden on the caregiver. Is there any advice you have for caregivers who are dealing with this, or how to, work through this, or if there are tips in ways of dealing with this more effectively?
Yes, for sure. I really appreciate that point, Matt, because I see this, many times in the clinic. I understand, how burdensome is their job. It's a 24/7 job, and this is like a chronic disease that really slowly progresses. So they live this for who knows for how long. So this is something that really creates a lot of stress for them. And if they don't understand how to deal with the symptoms, they might make things even worse. So we are very fortunate to have resources, which is very important. Patients just, no one talk to them. So they need to know, like, what are the available resources they can use. So that's what I try to do actually at initial visits. When I talk to the caregiver, I always make sure that they have time for themselves. And if this is something that probably they can have, home health aid comes for like a few hours, like maybe a couple of times a week, so they can have some time for themselves. They can go meet with their friends, do something for themselves. The other way we have been doing actually for over 10 years, there is a course called Savvy Caregiver. So this is a very, very successful course. We do this at the Brain Health and Memory Center in Beechwood. It's done in person and virtually. So I try to give the patient and their caregiver the information for that. Of course, it's mainly directed to the caregiver, and this helps them to deal with challenges, how they can redirect the patients, try not to escalate, and try to learn from other people who had experience with that. So I think it's very, very helpful. I have a very positive feedback from caregivers who did the course, and they came back for a follow-up, and they said that has been very helpful to us. This is a very important part of the management, just to pay attention to the caregiver burden for sure.
Great to know.
You've given us lots of reasons to be hopeful. You talked about the tools to diagnose earlier. You've talked about great, strong resources and focus on caregivers. So thank you for that. I feel like we're getting toward the end on a very positive note. Doctor, is there anything else that you would want to add to our guests out there that would give them encouragement? And I would even say help erase the fear, because I had the fear. And I will tell you that I will follow up and have a conversation with you, because that's what probably needs to happen. So anything that you could do to alleviate the fear in people and give them a little encouragement as we wrap up?
Yeah, the main message would be like proactive management. So we need really to be proactive on different levels. It starts with the patients to educate themselves about what are the potential symptoms, and also for the caregiver to pay close attention if they see something that doesn't sound right, that they seek attention, seek help from a medical professional. And also for the primary care providers, that they start to screen patients, even if they don't have symptoms, but they are just presenting for like maybe a wellness visit at age 65 or older. Why, would be very helpful to do just a quick screening, and see how things are. We need to encourage our colleague to refer the patients early. I think what happens now in the dementia field is really a revolution. I think there is a lot of clinical trials going on. There is a lot of hope. And you can imagine with this step that happened just 2 years ago, and even earlier than this with the medication that we are having now for the first time after, I would say, a long time of having many failed clinical trials, that we have now what we call the disease-modifying therapy. So we have amyloid targeting therapy, which are the infusions that are recently approved to be used in patients with early stages of Alzheimer's disease. So I think it's just the beginning. So I think I'm very hopeful, but I think it's a teamwork. So all of us have to, work together to help improving patients' care and also treat them with the appropriate tools.
Dr. Mohammed El-Kasavi, neurologist at University Hospitals Cleveland, thank you for joining us.
Thank you so much. Thanks for having me.
And we'd like to remind you that you can find and subscribe to this podcast wherever you get your podcasts. Search University Hospitals or The Science of Health, depending on where you subscribe. For more health news, advice from medical experts, and the Science of Health podcast, go to uhhospitals.org/blog.